Well, good evening, everybody, and thanks for joining us tonight. We have a different kind of a talk from our usual, maybe, because this one covers some distinct populations. Tonight, we have Dr. Meagan Costedio here from University Hospitals Cleveland Medical Center. She is a specialist in this area because whether she had initially thought that that was going to happen or not, the pediatric patients are becoming a real specialty and niche for her. Dr. Costedio graduated from medical school at the University of Vermont, and then she also completed her general surgery residency there in Vermont as well. Following that, she went on to complete her colon and rectal surgery fellowship at Cleveland Clinic, where she is one of very few people who was hired onto staff without completing a clinical associate year because she is that amazing. She's one of the most skilled technical surgeons that most of us who know her have ever seen. And it's a real pleasure to have her here tonight. Beyond her technical ability, she is a clinical genius as well. So she's going to share some of her expertise, and we really appreciate your time. Thank you so much for coming.
Well, thank you very much. That was quite an introduction, and you guys, Jen wants to stay with us, so that was the real reason behind that. So I'm going to talk to you guys a little bit about today's stuff, hopefully that you haven't had too much exposure to. I am going to focus a lot on the IBD because, of course, when we talk about pediatric transitions, the majority who we're going to be seeing are IBD patients. And there are a few differences, but really you're going to be happy to know it's like treating small adults. But we'll talk a little bit about the surgeries because I think we're more likely to see the patients, the Hirschsprungs and the anorectal malformations as adults, and we have to know what the surgeries are so we can know how to treat them if they get cancers and whatnot. So I don't have any financial disclosures, but this all started because I'm married to a pediatric surgeon. So I really know very little about pediatric surgery, but I realized that the pediatric surgeons, because they do everything else, weren't really specialists in colorectal. And so he was asking me on a pretty regular basis. And I realized that we can definitely learn from each other. Like, I don't know how to put a port in for Remicade, but he does. And then I do know how to do anorectal stuff. So we're going to talk a little bit about the workup and the post-op anatomy, because we do every once in a while, the Hirschsprung patients come up as adults, and we got to know what we have to biopsy, how big, where we have to biopsy, where the differences lie if you see young people with rectal prolapse, because this can be applicable to us. We'll see younger 20, 30-year-olds with rectal prolapse, and that's kind of more like the pediatric aspect, except for in patients with behavioral issues. Then the differences in care for kids with IBD, and then the benefits of transition, because that's something that we can help push the kids to if they're seeing somebody who maybe isn't as well versed. So let's start quickly with the anorectal malformations. So when you see somebody with an anorectal malformation, basically they're not passing meconium the first 24 hours, they don't have an anus. We look for the vactral. This is all probably medical, closer to you guys than to me, but medical school level of where you may have vertebral abnormalities, anorectal, cardiac, TEF, or esophageal atresia, renal abnormalities, and limb abnormalities. So the old looking for other stuff is really important. And again, that may be important to us. And this is on, I think, every ABSite, every board's question. Neurologic anomalies are the most common with the anorectal malformations. So real quick, again, old embryology stuff. Basically, this is all hind gut. So the descending sigmoid colon and the rectum all come from the hind gut. Again, always a favorite question on the boards. We have the urorectal septum. And again, this is all happening between 4 and 6 weeks of development. So before most women even know they're pregnant. Again, also a favorite. Then we have the anal pit or the anal membrane, and then these can grow again in the incorrect location. So they're classified into low and high lesions. And low lesions means you can do a perineal procedure. High lesions means usually you need a colostomy and then an abdominal procedure. So the male anatomy, of course, this is the most common, which is a perineal cutaneous fistula. Basically, the rectum just exits at the wrong place, so not in the sphincter complex. And again, this is a perineal procedure, pretty simple. It's not connected to the urinary tract at all. Again, this is the low type. The high types are where in males, where it connects to the urethral fistula, the prostatic urethra or the retrovesicle, so right into the bladder. So you can imagine those need to be done through the abdomen. The perineal cutaneous fistula, you can see that the meconium is not coming out through the anal pit. And again, these are pretty simple procedures. The high type fistulas, oftentimes you'll see meconium be passing through the meatus. And then female anatomy, of course, a little bit different. This is a perineal cutaneous fistula, also a pretty simple thing to fix through the perineum. But there are high fistulas, so basically a cloaca, meaning all three organs empty into the same vaginal tract, or cloaca with where everything is dilated, or you can have perineal fistulas where it's entering into the vagina, into the vestibule, basically. And this is the most common type of fistula in females. So the perineal fistula, there's a hole, and then here's the vaginal orifice. And then the vestibular fistula, as you can see, this is where the anal opening should be. There's nothing here, and then the meconium would be coming out here. So the high type fistulas are the cloacas, and those are much more difficult because we have to have multiple surgeons involved. Usually you'll have urology as well as pediatric surgery. So most of the high malformations, of course, are staged. So this is just some photos of what they do, and it's like totally scary, I think. So they basically kind of go up to the coccyx and spread through the muscles. They have these nerve stimulators so that they can make the muscles go. And then they find the pinhole, dissect out the mucosa, full thickness, kind of divide everything, and then close it all around it, basically inside the muscle complex. So you can imagine that their function is not quite the same as it would have been had they had everything congenitally come out where it was supposed to. So these patients commonly have issues with constipation, and a lot of times we'll join in, we'll have a bowel management program if they're at a big facility, which is really important part of their like getting used to normal functioning. Because as we all know, anybody that has children or has experience with kids, pooping is a problem no matter what. So throw in a little bit of trouble from the beginning and it's a real issue. So again, the normal question on these, you guys may have gotten it on your boards, which of the following structures is the embryonic origin of the distal anal canal? And that's going to be proctodeum. So it's either proctodeum or hindgut as far as the anything with the sigmoid. So what congenital anomalies occur most commonly in patients with an imperforate anus? We already said the urologic anomalies. So renal issues, again, very common. Embryologic hindgut, we've got sigmoid colon. So these should be like quick, easy answers where you know. An infant presents with an apparent abscess of the anus with a bucket-handled deformity, unable to pass meconium. Which of the following screening tests? So basically just another way to ask, basically, what's the most common anomaly with an imperforate anus? And that's renal or urologic issues. And then which of the following is the most frequent type of anorectal malformations in females? And we just went over that. In males, it's rectoperineal fistula. In females, it's a rectovestibular fistula. Well, let's move on to Hirschsprung's. This is all the quick. So the anorectal malformations are basically a hand-sewn coloanal anastomosis. There's nothing too crazy about that. They usually don't remove anything. Hirschsprung's is where the surgeries get a little bit complex, and you have to really kind of understand them as we go on, as we're talking about cancer down the road. So Hirschsprung's disease, it's pretty rare, 1 in 5,000 live births. Most of the time it's found in the neonatal period. 80% is rectosigmoid, which is good, but 20% may be long segment, including the entire colon. It's a 4-to-1 male to female ratio for low Hirschsprung's, 1-to-1 for long segment disease. So basically, you're less likely, if you're a female, you're more likely to have longer segment issues, and 10% of the kids are premature. It's related to a defect in the RET proto-oncogene. I don't think anybody needs to know much more than that. So the reason for it is a failure of cranial to caudal migration of neural crest precursor cells between 5 and 10 weeks, meaning the Meissner's plexus, which is in the submucosa, and Auerbach's plexus between the circular and longitudinal layers both have a lack of neural crest cells. So again, most of the time it's going to be rectosigmoid, and then it gets less and less as you go to the entire colon and beyond. If you do have more than the rectosigmoid, then it's more likely to be basically the whole colon, is what this picture is saying. And so you do these leveling biopsies where you can see the transition points, and you biopsy them at just where it starts to dilate, because that's usually where you're going to have normal. It looks abnormal, but that's the normal bowel. So infants, now again, we probably won't need to know this too much, but because most of the time, if we're going to see a new onset Hirschsprung's, we're going to see somebody with chronic constipation. And so then we're going to have to talk about how to biopsy those patients. Infants present with progressive abdominal distension and bilious emesis. They don't pass meconium usually within the first 24 hours. 10% can have severe enterocolitis diarrhea, and that can mean an emergent colostomy, and that's the most common cause of death for kids. And again, you got to do the rectal biopsy, which is absent for ganglion cells, and then you may do a contrast enema. This is a normal contrast enema in a baby, and this is an abnormal contrast enema. You can see this would be a descending or a transverse colon. So they have this cool little suction rectal biopsy thing. We don't know where to use this. For us, we would have to do it usually in the operating room, because you have to get a good, basically kind of a biopsy through submucosa. So you have to get down to the muscle. But in a baby, this is totally doable. So they do this usually in the NICU. When you're operating on the patient, you would take basically get to the submucosa. So you would get between the circular and the longitudinal layers and take a biopsy, and then you just suture it in, just like you have a serosal tear. So that's how they do their leveling biopsies in the operating room. And again, so you could either do it from the inside. So for us, if you're seeing a 20 or 30-year-old that's had chronic constipation that really has had no workup, and they're like, yep, ever since I was a baby, I've had this issue and I just can't poop, and everything kind of makes it through, but it just can't get out, then you may want to think about the biopsies. But you would do that, of course, just above the dentate line, these open biopsies where you would take a big, a nice big stitch and get underneath, so you would take full thickness, and you send those for frozen to make sure you get the submucosa. You do the aganglionotic bowel, of course, is resected. You make sure that the bowel has ganglions, and a lot of the times they'll do these in the really long cases. They may, do a staging stoma and then come back and do it later to get final path, because the path can be a little bit tricky. You have to have a good pathologist. And of course, we want to do a good surgery where you avoid pelvic nerves and urinary structures. Now, this is only one slide, and I apologize, but this is probably the part that is the most important for us, because we're going to see some patients with Hirschsprung's for constipation or for bowel dysfunction. The majority of the people we're going to see are just normal people who may have had these surgeries, but they have other colorectal pathologies. So it's really important to know what type of surgery they had. And if they don't, which of course it's going to be hard to find a lot of these op reports, they may be, I recently had somebody that had had it done in the 70s. So we have and she actually had her operative report that she had saved for many, many years. And so I knew what she had done. The Swenson is the easiest. So they basically do a coloanal anastomosis, just like we would do for any sort of rectal pathology. So that one's the easiest. That's the most straightforward. And so if you put your finger in, you can feel a little stricture. That's pretty simple. The Suave, they describe as leaving an aganglionic rectal muscular cuff. And what that means is really doing a submucosal. So it's kind of the equivalent of doing a mucosectomy. So you leave the internal sphincter and up to the levators, and then you anastomose the colon down but you do a mucosectomy. So it's not quite the same as a coloanal. So they still have the potential to have mucosal cells there when we do that. And then they have this aganglionic muscular cuff. And so a lot of people have, there's some thought that these kids have a harder time evacuating because they still have, their muscular cuff doesn't work. Then the Duhamel, which is another really a popular way, is you leave the anterior rectum, which is good. So basically you leave the portion of the rectum, which is under the prostate, so you don't have to worry about nerves. You leave that in place, but it's of course aganglionic. And then you anastomose posteriorly, so kind of a side-to-side anastomosis of ganglionated colon, and you leave them a little bit of a rectal pouch. So a lot of people like that, but of course the bottom portion of that doesn't empty well either. Of course, this is a very different surgery. So if you have a Duhamel and then you have somebody who develops a rectal cancer, it's actually a rectal cancer on the anterior portion of this. On the posterior portion of this, it is a colon cancer, right? So this is a confusing, difficult thing. I have not experienced this yet in my practice, but it's going to come up at some point in somebody's practice. So you really have to do, and the Duhamel should be pretty easy to figure out, again, based on when you put your finger in, you shouldn't feel a circular anastomosis, and you should be able to kind of see. You don't always. So important to think about. 70% of kids have a good outcome. And again, you have to remember these kids never knew anything different. So you may say, oh, their bowel habit's terrible, but that's what they know and they're usually okay with it. 15% will have severe constipation. 15% will have severe chronic diarrhea and soiling. 10% will have enterocolitis even after a pull through. And of course, the outcomes are worse in long segment. So things that can happen, you can get distal rectal narrowing after. Again, the question is it the distal colonic segment that is immodal, what you left? Is it just a stricture? Is it scarring or thickening the presacral space? Is it that you didn't get all of the ganglionic colon proximally? So there's a lot of different things. There could be twisting, a lot of, this is kind of similar to Jpouch dysfunction. Which can lead to active enterocolitis. So these are things most of the time I would say that have been kind of figured out and looked at prior to them coming to us, but these are things you may see if they're mild, and ways to, basically it will be a full gastrographic enema, flexible sigmoidoscopy, full probably defecating MRI to evaluate and see where the issues lie and if a redo surgery would be helpful or not. So this is this is my Ask Ours question. You guys are getting a prequel for this, for the next PEDS thing. So a 50-year-old comes to you, low T2N0 cancer, found on routine screening colonoscopy, no history. Workup's negative for Mets, CA 1. On history, he says he had Hirschsprung's as a kid, has an operation, doesn't have any op notes. States that he's perfectly fine with his bowel function. On exam, he has a cancer proximal to a circular strictured anastomosis. And so this is, I think this would be real important. So you look at the imaging with the radiologist and what is correct about your operative planning. The imaging won't be helpful as the exam's consistent with the Duhamel. So that's not right, because the Duhamel shouldn't have a circular anastomosis. So that one's out. Surgery will not have any effect on rectal surgery at all. Of course, we know that's not true. This guy doesn't have a rectum, most likely, right? Since this is a rectal cancer in a re-op pelvis, the patient will need an APR. That's not true either, because this probably is not a rectal cancer. This is probably a colon cancer, since we know that the majority of the time you're doing a sigmoid anal, the equivalent anastomosis. Not always, but the majority of the time. But the imaging may be useful looking at the vascular supply. So you would really have to look hard with your radiologist to look at the proximal colon to see if they took the IMA or the left colic, what the blood supply going, because if this was a descending like that gastrographic enema, if this was a transverse colon, then in order to get the appropriate blood supply, you'd have to take the left branch in the middle colic. And then you may say, ooh, that may be difficult to get your transverse colon off the right branch in the middle colic down to an anal anastomosis. So you would have a full conversation with that patient. So the anastomosis, or your ability to get him back together, isn't the fact that he's had a colonial or related to the cancer. It's more related to what's the blood supply you have to take to give him a good cancer operation as a 50-year-old. So it completely changes our outlook on these patients. So something to think about as we all will see these people down the road. Rectal prolapse. So I didn't know until I was married to my husband that prolapse happens commonly in kids, and it's most common in kids under 5 years old, noted at the time of toilet training. It's anatomic at kids, so it's a totally different thing than it is in adults. So we have a vertical rectum, meaning their pelvis hasn't curved yet. So it's kind of more of a straight shot out. They have a flatter coccyx. They don't have the same levator muscles because they haven't had to hold it. They're in diapers, and they have a low position of the rectum, and they're usually quite thin. So it is also more common in all underdeveloped countries, more related to parasitic disease, malnutrition, and diarrheal illnesses. So they're going to the bathroom more. Here we see it because of constipation, which is very, very common behavioral issue with kids. Pertussis, so kids that are coughing like crazy, cystic fibrosis, the same reason. Polyps, so like some juvenile polyps, and then autism spectrum disorder, so behavioral stooling issues. So you do have to do a sweat chloride test because, again, it can be a reason why you figure out that kids have cystic fibrosis. You do a contrast enema and then a colonoscopy. The treatment is the same. So it doesn't matter how little the kid is. You start with fiber, Miralax. Basically, I think every kid now the new recommendation is if you have a child, they just should get Miralax all the time. And avoiding the prolonged toilet time and straining, which if anybody has children on this knows that is not an easy thing. So operative indications, of course, are very similar to adults. So it just keeps happening no matter what they do. They have pain, bleeding, or ulceration. You can't reduce it, and you've tried everything else. So interestingly, they inject phenol, so they do sclerosis, similar to what we do for hemorrhoids. And basically that can cause enough scarring in the anal canal in those kids to basically get them through till they gain some weight and their pelvis changes so that it stops. And it works pretty well. So they both use hypertonic saline and 5% phenol. They used to use the Thiersch operation. I don't know if you guys probably have seen that through some of the talks where we used to stick a wire around the anus to help prevent, but I don't think too many people do that anymore because of the risk of erosion into the anus. There are sometimes they will do rectopectomies. It's not very often. And then a lot of the ped surgeons, because you do what you're comfortable with, we're doing PSARPs or posterior sagittal anorectoplasties, and then resections. And the outcomes, the cerclage worked okay, but the injections work great, like 10 to 20%, and they're of minimal risk, as you can imagine. So that's where most pediatric surgeons start. Resection rectopexy is just like for us. The PSARP really doesn't work very well. So really, for the most part, it's the sclerotherapy injections or rectopexy and resection. So just in case you guys get any young patients, certainly it wouldn't hurt to do some injection of hypertonic saline or phenol. All right, let's move on to IBD, because IBDs, as we know, as you can see, North America is in the red, where it is very, 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 very common here. And prevalence is now 15 in 100,000 kids. It's going up. 25% of IBD are diagnosed less than 18, which means that the majority of our patients, so a quarter of our patients, are going to be getting younger and younger, and it seems to be going up. Currently, there are 11,000 kids with IBD in the US. It's getting more and more and more. I'm going to start with toxic colitis and then work backwards, because toxic colitis, you can imagine kids, most people's feeling is kids are terrified of a stoma. We don't want to do a stoma if we can help it. But I would tell you that that is not true. Parents are terrified of stomas. Kids want to go to school and feel normal. They don't want to be sick. It's a different thing than adults. Adults have much more of a, particularly kids under 13. Kids over 13 is a little bit trickier, but kids under 13 want to be normal. They just want to feel good and go to school. They don't care if that means a stoma or what. So I would say toxic colitis, it doesn't matter. If you've got fever, bloody diarrhea, abdominal tenderness, colicky tendon anorexia, toxic megacolon, is that plus colonic dilation. And colonic dilation, anybody who's heard me talk, it's 5 centimeters. It's not the same as it is with Ogilvy's, 5 centimeters. Even in kids, it's 5 centimeters. It's the same. So it's the initial presentation of IBD in 30% of kids. So you can imagine this is pretty traumatic to people. They've not even been sick, and all of a sudden we're talking to them about a stoma. 20 to 30% of those patients will need surgery. So that's 10% of people with colitis will present and will need surgery for toxic colitis. Again, difficult discussions. Toxic megacolon, classically described in UC, but it certainly is happening in Crohn's disease too. So we just have to be mindful of it. This is the adult data. The mortality from the 80s is ridiculously high. And again, it's really important because they don't exhibit the signs of peritonitis, so it's easy to miss. Now with CAT scans, you can see micropurse back in the 70s and 80s, before it was common to do CAT scans, that was a little bit different. So certainly the death rate in kids is much better, thankfully, but it's led to severity indexes. So basically more than 10 stools a day, continuous blood in your stool, temperature of 37 and elevated temperature, elevated pulse, low hemoglobin, and a high SED rate is fulminant colitis. You throw in a colon of 5 centimeters, and for sure, we need to at least think about the OR. Jalen's diagnostic criteria, it's basically the same, except for they put in leukocytes, but basically fever, heart rate, elevated white count, and anemia. And then you can throw in dehydration, electrolyte disturbances, renal issues, altered consciousness. So the good news, again, in kids, toxic megacolon is overall an uncommon cause of death now compared to what it used to be. There is a higher mortality if you medically manage these patients versus early surgery. So basically what we believe is that surgeons should get consulted as soon as the toxic colitis comes in. Even if they don't need surgery, that's okay, but they at least need a discussion. And then at 72 hours, if steroids don't work, they go to the OR. And you can reduce the rate of perforation with that from basically by 2/3 with early surgery. So we decreased the mortality rate now to 0 to 2% with early recognition, better ICU management, early surgical intervention. Of course, we can do these even when they're perforated laparoscopically, and better post-op care, and the kids go home pretty quickly. This is that colonic dilation. Oftentimes you'll just see the transverse colon. So like, if you're not used to looking at stuff, especially if you don't look at your own images, oftentimes the radiologist won't even call this because it's not really considered dilation. But it definitely, that is considered toxic megacolon as long as you have fulminant colitis. There is a lot of people will get better from toxic colitis, so it doesn't mean everybody needs surgery. And of those patients, basically 50% of them will end up requiring a colectomy over a 13-year follow-up, which is a big deal. If you have a 12-year-old and they make it 10 more years, right, that's a big difference to go to a Jpouch at 22 versus at 10 or 12. So it's very reasonable to watch and do medical management, but again, if it doesn't work, you gotta move on. So you've got to resuscitate them, replace their K and their MAG. It's all the same for kids. Make sure you stools cultures, C. diff, blood cultures, KUB versus CT, tristeroids. I would say in kids, if they have failure to thrive prior to them coming in with toxic colitis, that would push me more to go to surgery, because failure to thrive is one of the major things in kids that we have to keep an eye for. And so if they're already on medications and they're having failure to thrive, oftentimes there isn't too much more we can do, and we're kind of at end stage anyway. The radiologic findings, that segmental transverse splenic flexure, or like lead pipe colon, disturbance of haustral pattern, normal caliber segments between the dilated ones, and then linear serrations kind of show penetrating colonic wall ulceration, which can be a bad sign. So again, you can see the thickness of the bowel wall. You can see between the small bowel and the colon, you can see that lead pipe where there's just no haustral markings. Or you can see this thumb printing where you get this super thick haustral folds. That's a bad sign about the edema in the colon. And we all know no response to steroids within 48 hours, worsening on medical therapy. So what surgery do? We know the subtotal colectomy and endoleostomy, the quickest and the best way you can do it. It doesn't matter. So laparoscopic, open, it doesn't matter. When people are in the hospital, kids included or adults, it doesn't matter. We'll oftentimes talk about tucking the rectal stump. So basically making a little incision above the pubic bone and put the rectal stump above the fascia there. So if it blows out, it becomes a wound infection rather than ruining your pelvis for your next surgery for the Jpouch. And the mortality rate, again, is still pretty serious. So it's important for us to recognize early and minimize that. Do not do a total prostatectomy and endoleostomy and toxic colitis. Of course, it's going to take you an extra hour or two. It more than doubles the mortality. Now, granted, that's old data, but still, we know for sure it is worse. It increases the rate of abscess, endothelial fistula, damage to pelvic nerves, and it decreases their chance for pelvic recontinuity. So most of these young people particularly will want a Jpouch. So don't try to get fancy in this setting of toxic megacolon. There's this discussion of the diverting blowhole colostomy and endoleostomy in really severe cases where you don't think you can get somebody through an operation. Pregnant women is one of the examples. The overall mortality rate is decent. We don't use it too much because now we can do things laparoscopically, and it's really, not as morbid as it once was, I would say. So for the patient options, of course, the majority of the time we're talking about a 3-stage pouch, which you guys all know. We do the total abdominal colectomy, we do proctectomy with pouch and stoma. We wait 6 to 12 weeks and we close the stoma. You can do a 2-stage pouch, which is laparoscopic, total prostatectomy and pouch and stoma, and then you wait and close the stoma. Or there's another option for the 2-stage pouch where you do the laparoscopic. So especially like in an 18-year-old kid, they have toxic colitis. You take out their colon, you wait 3 to 6 months, they're totally better, they're off steroids, they're off all the biologics, they feel a million times better, they gain back their weight, and then you do the proctectomy in a pouch with no stoma. So people will do that as well. Personally, I think the sequela of a leak after a pouch, which we know is about 10 to 15%, are so bad that really it's worth the extra time with a stoma. But there are some people you just can't get a stoma up, a proximal stoma, because it won't reach. And then there's also some people, that just don't want to do it for whatever reason, despite the counseling. So it's definitely an option. You guys probably know the majority of this, especially where you just had Dr. Ramsey's talk, but we just talk about expectations. So 6 to 8 bowel movements a day. There's a 15% risk of conversion to Crohn's disease. And we don't know if that means they always had Crohn's, we just didn't know it, or Crohn's and UC are really a very close combination of autoimmune diseases, and that you had UC and then you went into Crohn's. We don't know, but 15% of people will end up with Crohn's disease after a Jpouch, that they will have occasional incontinence, particularly at night, particularly when they age. About 12 out of 4,000 people, so a very small percentage, do develop cancer. So we do recommend pouchoscopy every 2 years, but 95% of the time patients are happy. And then we talked to them about bleeding, leak, which is again 10 to 15%, organ injury, like the ureter, 1% of the time, sexual dysfunction, 1 to 2% of the time, SMV or portal thrombosis, which is 10%. I say that might be even higher than that. It's a very common complication of both TAC and the pouch. And then dehydration and stoma issues are very common. So a lot of education goes into that. And then the long-term complications, we know that the fecundity risks were pretty significant when we used to do them open. So more than 50% of young women had difficulties getting pregnant. Now we know that with the laparoscopic data, and that's even with fan and steels, that less than 25% of patients were having issues getting pregnant. So I think as we get better and better and do straight laparoscopic, that will probably get better and better. I have reoperated on now a few pouch patients for a combination of issues. And I got to say, there's very few adhesions with the laparoscopic. Pouchitis and cufitis is the most common thing, and that's basically a kind of feeling like you have ulcerative colitis. Again, that happens at least 33% of the time. And of those patients, I tell them a third it's a one-time thing, a third it's a once-a-year thing, and a third it's all the time. And those people oftentimes want to go back to a stoma. Adhesions of bowel obstructions, pouch dysfunction or strictures can be an issue. And again, maybe that's Crohn's, maybe that's surgical. And then of course, hernias at the stoma site. So this is, you guys probably have seen the old pictures of the Jpouchs. This is with a single incision pouch. This is the same patient. This is what they end up with after stoma closure. So a lot better than the old days, that's for sure. So now the fun part of the operation is Crohn's disease, because I think this is much more, there's a lot more of an art to Crohn's disease. UC is a lot more simple, more cut and dry, but Crohn's is where the art comes in as far as medical. And if you guys do an IBD conference, this is where where things get more difficult. There's a lot of heated debate usually. So when do we operate? When patients aren't getting better on medications. That's pretty simple. So they're losing weight, they're missing work, they're sick. It's not just for pain, it's for a variety of those things, but usually there have to be really pointed symptoms. Family planning considerations. So sometimes we just operate because people don't want to be on Remicade and they want to get pregnant, and they're kind of, they have isolated TI disease. So that's a reasonable reason. Persistent symptoms without complications. So this is the person who maybe still smokes, is taking some narcotics, having a hard time making it to work, but there's no upstream dilation, there's no complications of the Crohn's disease. And so oftentimes we'll do a one-time, like, all right, let's see how you do. And those patients will oftentimes do better for a few months. And as soon as the microscopic disease comes back, they do worse again. And so that's when there has to be a lot of counseling to those patients. So we don't just reoperate every 3 months. because you're having mild pains. We figure out how to deal with the mild symptoms until you develop the complications. We all know the complications of Crohn's are stenosis, abscess, and fistula, and we see those often. But for kids, it is falling off the growth curve despite medications. And so it's not only the growth curve, but it's the weight curve. And so, yes, you can have little kids. So this green line just means you have a small child. So as long as they follow that same trajectory, it's fine. But when they're okay in a trajectory and basically they just start to fall off and plane off, that's when we worry. And that's oftentimes when the docs will start doing a fecal calprotectin. And I'll tell you, that's a large portion of who I operate on. So the kids don't have upstream dilation, but they have pretty significant, long segment disease in their TI, and we can't get them growing or gaining weight despite biologics. And usually they'll try 1 or 2 or 3, and then we remove disease, get them through that, get them growing. So it doesn't mean that's how we'll treat their disease long-term, meaning they'll just go to surgery as soon as, just because, but it's real important during the teenage years that they hit that growth spurt when they need to, or hit that, have the extra calories when they need to. There's also a lot they do with diet. So these kids, don't ask me how, I couldn't get an adult to do it by any means, even if I paid them, but they put kids on Ensure, like 6 Ensures a day, and the kids do better. So they have these these dietary, and they'll do it for months and months. And the kids are so they feel so crappy, and they're so sick of feeling crappy, and they don't want surgery, that they'll do these diets, which are totally crazy. I couldn't get adults to do it by any means, but so those are some of the things we do that are a little bit different in peds to try to get them to grow, to avoid surgery. But I end up doing surgery a lot because we're falling off the growth curve. So acute ileitis. It's reasonable to start with an ileocolic resection in an attempt to avoid long-term medications of isolated TI disease. Now, that's not how we normally would do it, but you have a 21-year-old, acute, came out of the blue, you started them on steroids, they got better, then they got worse, and then we're talking about Remicade versus, but they have a little micro perf, or then you can start with surgery. It's kind of like an appendectomy. A lot of people are diagnosed at appendectomy. We take it out and then we start over. And there are people that have that surgery and then don't need surgery for another 20 or 30 years. That's not all of them, of course, but that's certainly a way to not be on Remicade for the next 10 years until you need your surgery. But MRE can be a viable way, and there's some new studies out on PET MRI to try to figure out fibrosis versus inflammation, basically based on enhancement gains, to try to figure out who is going to get better with medications versus who's going to need surgery for the fibrosis. Of course, anything with Crohn's, minimally invasive, is the way to go. These people need multiple surgeries throughout their life. You want to decrease their risk of adhesions, increase their risk of having all of those surgeries done laparoscopically, which minimizes their risks of EC fistulas, hernias, tons of other issues. We all have those Crohn's patients that have a mesh all through the abdominal wall, and they've got a fistula through the mesh. And, luckily we don't see that anymore. It used to be everybody that we took care of for a while. But the operative principles are, it shows you doing it with your fingers, which usually we do even through the mini laparotomy sites. You can run the bowel, but you can do it laparoscopically, and usually you can see, and then of course you just take out what you need to, you don't need big margins there. So this is a great example of, it's a little choppy, but the upstream dilation. So laparoscopic running of the bowels. We're at the TI, and then you can see that bowel just explode. This is a kid who had 10 centimeters, horrible TI, horrible small bowel dilation, and was really, really malnourished. He lost, I think, 60 or 80 pounds. So Crohn's disease with an ileocolic stricture, should we dilate them? So we all know that it, of course, has to be a short segment. It's got to be less than 5 centimeters. But why don't we just operate on them? Of course, Crohn's disease surgery, our goal should be minimizing surgery, maximizing how they feel. So if you have patients with an ileocolic stricture, now it's hard because sometimes we find an ileocolic stricture on scope, but we don't see it on imaging. So you can imagine, and those patients aren't symptomatic, those people are going to do better, right, than people that are coming in for an obstruction. So with one dilation, it's about 40% end up going to surgery because the dilation didn't work. They either got a fistula or an abscess around there, or ended up with a perforation. But 60% don't have surgery after 1.8 years. Repeated dilations still quite a significant, again, about 60% with a mean follow-up of 4.7 years ended up with no surgery. So we really can delay surgery with dilations. They do work. Now, of course, there are the risk of perforations, there are failures. And so how do we figure out who's going to do okay with surgery or not, or with dilation versus with surgery? Because I will sometimes dilate these people, sometimes the IBD doctor as well. So the biggest thing is if the patients have radiographic proximal bowel dilation, there is a much less chance that the dilation is going to work. So if radiologically, when you see that they have big dilated upstream, it's unlikely that your dilation is going to work, which makes sense. It's a clinically significant. If they're symptomatic, same thing, it's less likely it's going to work. So basically, if you have a small stricture, you find the patients aren't terribly symptomatic, it's more likely that those people are going to do better with dilation, even if they need repeated dilations down the road. So if you see somebody with upstream dilation, you see somebody with a lot of symptoms, odds are they're going to end up with you with surgery. You could certainly try a dilation, but so Crohn's abscesses, this is the one we usually are talking about in our IBD conferences, right? They're sick, they're in the hospital, usually very frustrated. So should we just take them right to surgery, or should we percutaneous drain them? There are goods and bads to both. Now, this study is a European study. So when you look at the length of stays, you have to realize it's not going to be the same as in the US. So if you just take the patient to surgery, and again, these are small numbers, your total hospitalization time is close to half. But I mean, that's still 4 weeks. And we all know there aren't many people, especially healthy Crohn's patients, that are sitting in the hospital for 4 weeks. So we have to take it with a bit of a grain of salt. The important point of this is that you're taking out a significantly longer length of bowel if you operate emergently. And again, that may be the difference between shortcut down the road and not. So I definitely think it's worthwhile to think about percutaneous drainage. Now, the problem is who is going to be okay with percutaneous drainage and who's going to fail. So it's figuring that out. So the people who are going to fail after percutaneous drainage are much more likely to have colonic origin of disease. So if you have an ileal origin of disease, yes, some of those people fail, but the majority are colonic. So if you have a colonic, again, that you know your problem is in the sigmoid colon, not in the TI, then those are the people that are more likely to fail. So that's somebody you may go straight to surgery for, or multiloculated abscess, which makes sense, right? When you see those like horrible septated things, those are of course more likely to fail. So multiloculated abscesses originating from the colon, those are much more likely to fail with percutaneous drainage. Those are people you may think to take to surgery first and not even attempt the perc drainage. This is oftentimes those perc drainage tubes leave it super nice. You know, you got a little, like I just leave the tube in. Sometimes I cut the tube with the ligashore. They stick right to the intra-abdominal wall, which are nice. An elective surgery after successful percutaneous drainage means not only do you have a decreased rate of stoma creation, but you have, again, you take out less bowel, and you can see it really kind of focal, you minimize that inflammation down to a focal point when you can get the percutaneous drainage in. So the majority of us will do percutaneous drainage, again, in the right setting, particularly with TI disease. So fistulas, common in Crohn's disease. So which fistulas do we give Remicade, right? Because there's some data on that. Which fistulas do we operate on? So most of the time in patients who haven't had surgery before, we're going to be talking about an iliovesical or an iliosigmoid fistula. 30% will involve the sigmoid. Ilioduodenal fistulas are much more common after your first ileocolic resection, because that usually the anastomosis will lay kind of right on top of your duodenum. Those, of course, are a little bit more difficult to deal with. And then cologastric fistulas, and if you have transverse colon disease. Now, this CTE study shows that that if you see a stenosis, your CTE number of lesions and what they found is pretty close. Fistulas, only a third of fistulas are seen on the CTE. So that's why Crohn's disease, you know, if anybody, when you first start, you're like, we're doing ileocolic resection. Why the heck do we have to put the patient up in yellowfin? you got to look at the imaging, and if the TI is anywhere near your sigmoid colon, you got to be ready for it, because a third of the time you won't have seen those fistula and you're not ready for them. And again, if it's in the sigmoid, you might need to be doing a sigmoid resection. So you want to have your patient ready on the table. So fistulizing disease, we all know, right? It's harder. You're more likely to have to convert to open. You're more likely to have to take out two different things. You might have to repair the bladder. You might have to take out the sigmoid. You're more likely to make an ileostomy, and they stay a little bit longer. No surprise, fistulizing disease is harder. I would say that you still should be able to do it laparoscopically for the most part. Now, not always if it's like a perforation or whatever. The role of medical therapy, this also shows that if you have sigmoid origin of your fistula, you are not going to get away without surgery. So basically, it's not going to work. The percutaneous drainage is not going to work, and Remicade is not going to work. For some reason, colonic fistulas act differently than the TI fistulas. But a third, 13, like basically, like almost half of the patients with TI fistulas will get better with Remicade. So it's certainly worth a try as long as they do not have any sepsis or any abscess. So just something to think about. No, it doesn't mean it will work, but if the patient's minimally symptomatic, it's something you can try. So the next question is, sorry, my thing flicks over. So when you have Crohn's colitis, so you've got the sigmoid fistula, what do you do? What do you do for the surgery? The old teaching was you got to do a total colectomy and ileorectal anastomosis, because the disease always comes back and you want to prevent future surgeries, which probably was the right teaching back in the day when we didn't have biologics. We didn't have any medicines other than prednisone, right? And Acecop. So basically nobody had any way to prevent disease from coming back. But now it is different. And this is the big difference in kids. So anytime you go to a meeting, people talk about, well, you should do a total colectomy. Well, the data is for a total colectomy. Basically, what you're looking at here is a 30 to 65% risk of recurrence anywhere around 10 to 15 years. So if you do a total colectomy in an IRA, what are the odds that the next surgery, you've got a Crohn's patient, that you're going to be able to salvage and have them not have a stoma? So you've got a 13-year-old, it's like slim to none. Basically you're now talking a low ileorectal. You probably shouldn't be doing a Jpouch if they've got any sort of anal or small bowel disease. And so they're pretty hosed at this point. So we looked into the segmental colectomies, and the recurrence rates are basically almost exactly the same, 30 to 66%. So I would say, at least me, is that you guys are all starting out in your own practices. Like, I would definitely do a transverse low rectal anastomosis versus an ileo low rectal without a Jpouch in these patients. So it means potentially sparing these people another 10 to 15 years without a stoma. And when you're talking about younger patients, it's definitely worth it. But you have to educate them, and you have to let them know, yes, your disease is going to come back. And again, in the days of biologics, this data is definitely going to get better and better and better. So I think now there's no question that segmental colectomy is the right thing to do in the setting of Crohn's, not total colonic Crohn's. I'm talking isolated segmental Crohn's. And again, when you actually look at, and this is 2001, so this is really, pre-Remicade. If you have a TAC with IRA, the 10-year recurrence is 58%, segmental is 47%. So it's basically 6-to-1, it's the same. And if you do a segmental, you have the chance to rehook them. You get one more shot probably at their low rectum to get them back together. Now, the recurrence rate is low if you do an ileostomy. So that is an important thing to talk to them about. But I would say the majority of young people aren't too excited about that, talking about a permanent stoma. And then one of the options that we certainly can do is just fecal diversion to just calm it down. Now, the reversal rates aren't great, but at least it introduces people who may end up with a permanent stoma to comparing, okay, this is what life is like with a stoma, this is what life is like with Crohn's, and actually see which is better and which is worse, which can be very helpful. So, and again, in the data, we'll have more and more data coming out now that we have biologics and we have preventative treatment. So Crohn's disease and pouches, kind of the rule of thumb is never do a pouch in Crohn's with small bowel or anal disease. Of course, we've done tons of pouches in Crohn's, most of the time by accident. So when we look at 200 patients that we accidentally did, so 10% we knew and we were pushing the envelope because they were young and they were really wanted to do it. But 47% of the time we took the colon out, we made the pouch, and then whoop, they said it was Crohn's. And then 43% of the time, then we got Crohn's later down the road. The pouch retention rate is 71% at 10 years. Now, that doesn't mean that people are wonderful, but it means that 71% of people survived likely without a stoma at that point. So again, when you're talking about young people, this is something we certainly can do, but you have to talk to them about pouchitis, pouch-vaginal fistula, the need for medications, postoperative sepsis rate. So it is something we can offer, but I wouldn't suggest. So now let's move into transition of care. Why is transition important? So now this is a study, of course, this isn't randomized. They said, all right, do you want to transition? There's a whole set of people you can meet as social worker, and where we're going to get you ready to meet your IBD doctor, and you're going to meet an adult surgeon, you're going to have your kid, So 44 patients transitioned. There's a statistically significant decrease in the patients who needed surgery. So big deal, right? Like you're more likely to need surgery if you don't transition. And that's because you're more likely to not go to clinic, you're more likely to not take your medicines, and you're also more likely to not grow as expected, which is crazy. You're more likely to get more radiation, more radiology studies, and you're more likely to be admitted within the first 2 years. So the transition, now granted, it's a self-selection, right? The kids who do the transition program are probably more likely to behave, where the people who weren't were probably the kids that were less likely to behave maybe. But still, it shows you that if we can get kids to understand how important it is, then it makes a huge difference in their care. For people who don't transition, in that they will have an increased risk for opioid dependency. We all know that that's an increased risk for death now, increased tendency to smoke, and there is a huge risk in unrecognized depression in these kids. So 36% of adolescents with IBD were given the depression screen and had a positive screen. Just so you guys know, the suicide rate is 10 in 100,000 in 2018, up from 6.8. So it's almost doubled in 10 years. And in 2019, and that's old data, 9% of high school students attempted suicide. Attempted, but 9% attempted to kill themselves. So this is really important stuff that we have an ability to meet an 18-year-old and see if we can help them. Now, hopefully this is more on the GI side, but it's not for sure. So this is important stuff for us to talk to them about. And I talk to everybody, particularly the kids who seem to be having a hard time, talk to them about depression, talk to their parents about maybe getting them to see somebody. So even in a small scale, even if they don't have a full transitional care clinic, this is important stuff that we can have a real impact on. And we all know that depressed people have a harder time sleeping, have a harder time tolerating pain, right? They're going to have a harder time with their diagnosis. So barriers to transition, there's this social economic model of readiness to transition, the SMART transition. And then there's pre-existing factors, so stuff we can't really change, basically a cultural aversion to physicians, that patients don't have health insurance. Like these are things that we can help with but can't fix. Their medical status or risk if they're born with things, or neurocognition or IQ. So basically maybe an autistic kid doesn't have the same ability to potentially lead his healthcare that another child might. So there's some things that we can't change, but there's a lot that we can change, and there's a lot that we can modify. So we can help educate, we can give them the skills to, this is how you call a pharmacy, this is how you get your medications, help to change beliefs and expectations. Like instead of that, just, I don't want to be sick, we change it, well, this is your diagnosis and this is what to expect out of it, and that you will have to keep, working on things. Developmental maturity for the patient, and then working on their goals, motivation, relationships with their parents, because that's a hard transition out, and then working with the providers and the patient. So we talked about that a lot of these things we can't change, but there's some we can. We can advocate on insurance. Almost 30% of Americans 18 to 24 don't have health insurance. And again, that's with we're supposed to be able to get our parents' health insurance until 26. So you can imagine who's paying for Remicade 100 grand a year, right? When you don't have health insurance. So developmental maturity, that's a hard thing. This is, it's trying to get people to make their own appointments, to put things in their phone, to bring their health history with them. So basically educate them that what it means to come as an educated patient, to know their disease, figure out their personal history instead of just say, mom wrote it down for me. And then really adjust their expectations and goals to what they're going to get out of their adult physician transition. So there's a lot of dependent relationships. So there's a lot of, we call it, it's a well documented that 25% of parents not only know that their kid needs to transition, but thinks it's reasonable that they will continue to act as their healthcare power of eternity for the rest of their life. So 25% of parents have no plans in ever transitioning the care to the kid. 50% of parents, which is the majority, want to turn over the care to the kid, but don't know how, and they don't want them to get sick in the process. And 25% of parents weren't there to begin with. And so that's another really tough group where, if a parent member is sick, for example, and they can't, the kid may feel that their sickness is less important than the parents, and so they just will stop going to the doctor. So there's a lot of issues with the parental aspect, and then of course psychological conditions, acute crises, family function issues that go into this. A death of a parent can basically stop healthcare for kids. And then the perceptions when kids are in the pediatric world, there's oftentimes a lot of hand holding, as you guys know. You guys all did peds. There may be like to get an IV. There's always EMLA. Like that changes when they move to the adult office, and a lot of people aren't ready for that, and that they feel that they're not getting the same care. So it's important for the adult physicians to get the medical records ahead of time, for the patients to understand that they need to bring their medical records that are important. You have to find somebody you have to be able to discuss sex. You have to be able to discuss, like for example, Jpouchs, you got to be able to discuss anal intercourse with kids. You have to be able to discuss depression. You have to be able to discuss pregnancy. There's a lot of aspect in adult providers, especially in that transitional aspect of things. And then there can oftentimes be poor communication. And as you know, if things aren't easy, a lot of people don't want to go. So we have this transition readiness assessment question form. So this is supposed to be done by a social worker, again, on the PED side of things. And then, can your kid do this? Basically, you should have the kid be filling this out. And that's where you start, like, okay, these are the things I need help with. And it's an excellent way to kind of get, and probably anybody with kids on the call, like, this isn't a bad idea for the rest of your kids, even if they don't have a chronic health condition. We do this with diabetes, multiple other kids issues. And so the plan starts at age 12 and trying to figure out, like, okay, where are the knowledge deficits? How do we continue to educate? And then establish the goals as they go forward and move on, so that we get to a point where they're making all of their appointments. They know they know what their health insurance is. They have their card with them. They can make it to their own Remicade appointment. And again, the goal is, especially by the time they get to college, for them to be able to make it to adult providers and do all this on their own, which you can imagine anybody that like this is not an easy thing for kids. It requires pediatric GI, adult GI, a transition coordinator. That's the person who's going to do a lot of the legwork in like an hour appointment at least. Psychologist, that's for the depression aspect of things and arranging appropriate referrals if they need it. Social workers, and that's big on the insurance aspect of things. And then a dietitian reviewing the growth parameters, nutritional balance. I can't tell you how many kids come from college, they've lost 40 pounds because they're sick from their Crohn's, and they're like, well, I'm just eating differently. It's not my Crohn's, I'm just allergic. I just had this, I drank too much, and they like totally didn't understand that it's not what they're eating. So kids that transition are more likely to adhere to their meds, go to their appointments, and less likely to need surgery or to go to the hospital. 29% of people don't have insurance, so it's our job to keep advocating for them. 36% of adolescents have depression, so it's also our job, even in our adults, to recognize this and get them treatment and give them help. Toxic megacolon, toxic colitis plus 5 centimeters. Jpouch surgery, we should do it 3 stages as a rule. You guys know about Jpouchs. Acute Illitis, you can use surgery. MREs are useful to grade fibrosis. I see strictures. Half will avoid surgery with dilation, but dilation is not good if you've got upstream dilation symptoms or it's been a long time since your last surgery. Abscesses, a third will be treated with percutaneous drainage alone. Initial surgery decreases the length of stay, decreases the number of surgeries, but increases the length of bowel removed and increases your need for stoma. And then factors that are associated with drainage failure are abscesses, steroid use, colonic origin. And then fistulas, be ready for them. They're oftentimes not seen on imaging. That a third of fistulas will heal on biologics as long as there's no abscesses. And most of the time, colonic disease is not counted in that. Those are more likely to fail. And then colonic Crohn's, segmental colectomy is very good for Crohn's and gives you chances for more resections in the future without a stoma. All right. Hopefully that was helpful. I didn't talk a lot about the peds, like the constipation and the pelvic floor issues, because, you know, it's not really surgical. And like we all know people have those issues and hopefully they have a good referral place for those. But that is some of, that is some of our job is pelvic floor dysfunction and things like that after some of the anorectal stuff. But I don't have a thing for that. All right, I got a couple questions.
Yeah, can you see them in the chat box?
I do.
Yeah, it's out.
All right. Is there a preferred operative approach used in adults with Hirschsprung? So usually adults with Hirschsprung are going to have very short segment disease. I have no idea. It's such a small portion of people. I would say probably a coloanal. I mean, we're all so comfortable with a coloanal, right, from cancer. I think that would probably be my choice rather than a Duhamel. Like I've never done it. I wouldn't know how to do that in adult. And you can imagine things are so dilated right down to the anus usually in those cases, because the issue, again, it's usually ultra short segment. And then I do get referrals from pediatric surgeons. The majority is from pediatric GI, but I get quite a few pediatric surgeons, mainly anorectal fistulas and stuff that they've had. Like recently I got a horseshoe abscess. You know, they've all had like the $1 million Crohn's workup and they just have a horseshoe fistula. So. All right.
Does anyone else have any questions for Dr. Costedio?
Actually, I'd like to ask a question. I was curious, and I may have missed this because I'm driving, so I can't see your slides. But you had mentioned a cohort of Crohn's colitis patients, and you said that 10% of them got a Jpouch, just, you were pushing the envelope for whatever reason. They were young or it was isolated to the colon, whatever. I guess I was just curious, you had mentioned that 71% of all the patients, maintain their Jpouch. Was it the same for that 10% cohort population?
Oh, I have to look back. The data is worse for the people who developed definite Crohn's post-op versus just that we thought their path was Crohn's, and for the known Crohn's pre-op. For sure, but it's still not terrible. It's still in the 60s and 70% over 10 years.
Thanks.
Yeah. So, but it is worse than the people who we just act like they have no symptoms, no signs of Crohn's, and we just found it on path. All right, we got another question. In the situation of an adult who has a Duhamel but now develops a colon cancer in the pelvis, how is the treatment of this pelvic colon cancer different from rectal? Good question. So again, I don't know that there's a lot of data behind it, but you certainly should have a lot of the rectal cancer treatment is, like the radiation is more about the lymphatic spread to the groin or to the internal iliac nodes. So that's why we, for the most part, radiate. It's not like really some of it's the direct expansion, but the most of it is that lymphatic channel. And of course, we don't have that for a colon cancer. So I would say I would not recommend radiation in that setting, and I would treat it as a colon cancer because they do have cirrhosis. They have all the layers of the colon there. And then again, we don't have to worry about the internal iliac nodes or the external iliac nodes. So I would treat it as a colon cancer, even though it happens to lay in the pelvis. But the pathophysiology should still be of a colon cancer. Of course, you would have to, it's a redo, it would be a harder operation. You know, there's a lot of those considerations to be had, but the actual like, you know, cancer biology, I would say it would still be a colon cancer, if that helps. Good questions, guys.
Well, if that's all the questions, thank you all for coming. Thanks for spending the evening with us, Dr. Costedio. We appreciate your time.
No, thank you guys. Get on to your night. Thank you. Great to see everybody. Good luck, everybody, with interviews and jobs and all that stuff.
Thank
Bye,
you.
guys.
Good night.